Um, so this patient raises a question regarding remission after transsphenoidal surgery for Cushing's disease, and I just thought it would be interesting to review this recent publication, which was actually a two-center study, one from Boston and one from I think it was Pisa in Italy. 620 Cushing's disease patients in total, and these patients were all evaluated postoperative days 3 to 5, using a variety of parameters, some with early morning serum cortisol, etc. And these patients were divided into two groups. There were a group of 446 patients who were defined as having immediate control of their Cushing's, and of these 327 were hypocortisolemic and 119 eucortisolemic. And then a second group who were not controlled of 174 patients. These were patients with persistently elevated cortisol. And these patients were reevaluated between 38 and 50 days. And what was interesting was that some of the patients who were not controlled in that immediate postoperative period remained uncontrolled, 148 of those patients. But 17 of that group at the subsequent evaluation now had normal cortisol, and 9 patients actually had become hypocortisolemic. And in terms of what things were predictors of immediate control versus delayed control versus not controlled, immediate control was more common in microadenomas than macroadenomas. Immediate control was more common in patients in whom the ACTH-producing tumors were confirmed histopathologically. And interestingly, also the postoperative ACTH, which correlated with serum cortisol and urinary free cortisol, was more often elevated in the group that did not have disease control. And in terms of mechanisms as to why this group of patients that exhibit this so-called delayed control may occur, one theory that has been proposed relates to partial autonomy due to adrenal hyperplasia. Against this, however, was the elevated ACTH seen in the delayed control group, which would argue against the cortisol production immediately after surgery being due to an adrenal origin alone. Another possibility is that perhaps there's some residual corticotroph tumor initially, which subsequently becomes necrotic and dies, and that possibility is indirectly supported by the negative histopathology in the delayed control versus the immediate control group. One other possibility is that there's some degree of cortisol cyclicity, which may play a role in the variable postoperative cortisol, and this is supported by the finding of increased risk of recurrence in the delayed control group of patients, which in this group there were 43% exhibited this cyclicity in the delayed control versus 14% in the immediate control group at 4.5 years. However, this does not explain the 18 patients who actually went on to develop hypocortisolism. So in conclusion, it suggests there is a small but significant group of patients with Cushing's disease who, if we evaluate them in the immediate postoperative period, may have testing results which are somewhat misleading, in that 18% of the patients in this study with initial hypercortisolism developed either low or normal cortisol at a interval later between 45 and 53 days. And there is also a group of patients, about 8%, who will be eucortisolemic immediately after surgery, who over time will become hypocortisolemic. And so this raises questions about decisions perhaps to take these patients back for second surgery, to do radiation early after the the surgery based on these results, which may, as this study suggests, be somewhat misleading in albeit a minority of patients.